Hello, my name is Dr. Robert Farini. I'm a consultant in urology at the Mayo Clinic, Arizona. In this brief seminar, we're going to discuss the role for surgical removal of the prostate in the management of prostate cancer. In this country, the dominant technique used to remove prostates these days is the robotic, minimally invasive radical prostatectomy. It represents about 85% of the prostatectomies performed in the United States. The other 15% are still performed in an older traditional method of using open surgery with larger incisions. We're going to discuss primarily what it means to have surgery to have the prostate removed for cancer, independent of which technique is used. In this day and age, we categorize our prostate cancers as low risk, intermediate risk, and high risk. And these categories roughly define the risk of the patient developing recurrent or metastatic cancer in their future. In all of these risk categories, surgery does have a role. The technique of the robotic removal of the prostate involves 6 small holes made in the lower abdomen to insert the robotic tool that the surgeon is controlling to do the surgical dissection. When we're doing the open, older traditional operation, a small incision is made in the lower abdomen in the midline to do the work. With the robotic approach, that again is the dominant form of surgery in this country, the advantages over the traditional approach are modest but present. There is less bleeding, and typically at experienced centers, the risk of a blood transfusion with a robotic removal of the prostate is less than 1%. There is an advantage in terms of faster recovery to the patient because there is not a major incision, and perhaps slightly better outcomes in terms of return of erectile function. In terms of cancer control and return of urinary control, the traditional operation and the minimally invasive robotic operation have roughly the same outcomes. A patient who undergoes a robotic prostatectomy should expect typically a one-night stay in the hospital and a penis tube called a catheter being in place for 1 week after the operation. Most patients can resume significant heavy physical activity within 1 month of their surgical procedure. The advantages of the surgical approach in the management of prostate cancer are these. Number 1, because the prostate is being removed completely, we get tissue staging of the disease. Not only is the prostate removed, but the seminal vesicle glands that are attached to the prostate come out, as well as a dissection of the regional lymph nodes to understand whether or not the cancer has spread in a microscopic fashion. This analysis of the tissue that we get with the surgical management of prostate cancer allows us to plan more intelligently and more effectively potential combinations of treatment that will be required for the patients who have the more aggressive and more ominous prostate cancers. That's one distinct advantage of surgery over perhaps radiation or surveillance. The other advantage is that the metric that we use to follow a patient who's had surgical removal of their prostate for cancer is very black and white and clear cut. The patient's PSA blood test has to go to undetectable. That is the expectation if the surgery has accomplished its goal. If it does, no further therapy is typically planned. If, in fact, the PSA goes down to undetectable and later rises, we recognize that very early in the course of events and can initiate secondary treatment in a timely fashion. When we're talking about higher risk prostate cancers, no matter which form of therapy is chosen as the first step, radiation, surgery, hormonal, whatever, these patients are very likely in their lifespan to require combination treatment. So again, surgical staging, understanding the extent of the cancer, helps us plan the combinations that we're going to use most effectively. We know that these cancers, particularly for younger men, will require more than one treatment in their lifetime. The advantage of starting out surgically is not just getting tissue staging of the disease, but also after the patient heals from surgery and regains their functions, continence, sexual function, whatever. The radiation can be planned as a next step in treatment, and the patients tolerate the two treatments together very well if we follow that time course of delivery, surgery first, later radiation. For the men who start with radiation, unfortunately, they're burning a bridge somewhat for surgery being used later for the management of their disease. The reason for that is once tissue is radiated, it will not heal. Now, we can take out radiated prostates surgically, but the functional after effect to the patient is typically devastating in terms of incontinence and other issues because of radiated tissue not healing. Those are the good things about surgery. There are some negative things about surgery, things that make patients seek other alternatives. First, loss of sexual function. This can certainly be a byproduct of the surgical procedure. There are techniques to try and preserve the sexual function. The robotic approach to the surgery is a very nice tool for doing that. And when experienced surgeons are aggressively preserving the fine nerves that help control the erection process, the majority of patients who go into the operation with good sexual function, especially younger men, will see return of that function. But they never get instant gratification on that. It always takes a period of time where they see these erections gradually come back. The older the patient, the less functional the erections going into the operation, the slower the course of seeing that function come back. Men can always be managed with other treatments to try and give them back their erections if they lose it to a surgical procedure or any other form of prostate cancer therapy. So that's a big issue for many patients considering their prostate cancer treatment. But with surgery, the thing that scares more patients away from it than that is the fear of being left with urinary incontinence, leakage of urine, and the need to wear protective pads to be socially acceptable. And this is a real concern. If we look at a busy center like the Mayo Clinic, where we do very large volumes of these procedures with very experienced surgeons, about 5 to 7% of the men that we operate on are left with some degree of a permanent, significant incontinence that they are very unhappy with. They come back a year or more after surgery complaining. There's another 5 to 7% that'll have very mild incontinence as an outcome of the surgical procedure. The other 85 to 90% of the patients, once they heal, and that duration of healing can be variable, but once they heal, they're left with urinary control that they're comfortable with. So who are the men that are at greatest risk for being incontinent after surgery? Well, the first variable that's important is age of the patient. The older men well into their 70s, always have the highest risk of ending up incontinent after surgery, independent of surgical technique. The second variable that's important is massive obesity. And the third variable that's important as being a risk factor for incontinence after surgery is a very, very large prostate with pre-existing bladder dysfunction. But for the majority of patients that we operate on, they will have an incontinent phase that can take all the way up to a year or a year and a half to completely resolve, although for most, it's a matter of several months. Close to 90% of the patients who undergo these procedures end up with urinary control they're comfortable with. Other risks of surgery, we already discussed bleeding. With the robotic approach, the risk of bleeding to the point of a blood transfusion is less than 1%. Anytime a patient has general anesthesia for surgery, there's a risk of death. And looking at the thousands of patients that we've operated on at our institution, we have not seen a death from the robotic removal of the prostate. So that's extremely unlikely to occur. There is also the risk of injuring the rectum because the prostate sits on top of the rectum. And when the prostate is removed, it is possible to make an injury to the anterior rectal wall, which is something we never want to do. In the older era of doing the traditional operation, the vision that we had in doing that dissection plane is quite different from what we see in the robotic era. And even back in that time frame, the risk of injuring the rectum was around 1 to 2%. In the robotic era, because of the visibility that we have using this technology with 3D high magnification vision, the risk of a rectal injury is a fraction of 1%. So again, surgery has a very important role to play in the management of prostate cancer in appropriately selected patients. Men up to the age of the mid-70s should always consider this option for managing their cancer, as well as the option of radiation, or for the low-risk prostate cancers just going into a surveillance program. For the very young men with prostate cancer, and we see them as young as men in their 30s, surgical management should be the mainstay, the first step, and hopefully the only step in managing their cancer. There are patients who are less desirable choices for surgical intervention. These are the older patients who have significant medical comorbidities because of the risk of any operation or anesthesia to the patient. Also, the older patients have the greater risk of incontinence being an outcome from their surgery, independent of how competent their surgeon is. Also, men who have severe neurological problems and lack of bladder control going into surgery would be generally poor choices for surgery, but frankly, they don't do very well with radiation either in terms of their urinary outcome. So again, my name is Dr. Robert Farini. I'm a consultant in urology at the Mayo Clinic in Arizona, who focuses primarily on prostate cancer management. Thank you for watching this website and gaining this information. We would encourage you to seek as much information as you can through websites like this to be comfortable in your decision process on how you want to manage your prostate cancer.